Now, let's shift gears and talk about prioritizing the problem list. We've already learned how to label the primary problem and specify the urgency and chronicity of the diagnosis. The next step is to apply this approach to every medical problem found in your assessment of the patient. This is how we keep track of patients with multiple medical problems. Generally, you will add additional problems to your patient's problem list based on information from 3 sources. These include the history and physical, diagnoses already in the patient's chart, and new lab or imaging results. Your first source is the history from the patient. If you obtain information during your history and physical exam that is clinically concerning, you should add this to your problem list. For example, let's say your patient originally presented with worsening shortness of breath for 3 days. During your physical exam, you notice that they have a large lesion on their nose that appears cancerous. Upon further history, your patient tells you that they've had this spot on their nose for years and have been meaning to get it checked out. Recently, it has grown in size and has bled on and off. Now, you have an additional but unrelated problem to their chief concern. You should add this onto your problem list. The second source is the list of diagnoses already in the patient's chart. Remember that you should trust but verify the information in a patient's chart. Ask yourself, are these diagnoses correct? Has the diagnosis resolved? Also, there are instances in which the patient may have no information in their chart. For example, if they have never sought care in your health system before. Returning to our example, we look through our patient's chart and find a documented history of type 2 diabetes, hypertension, coronary artery disease, and gastroesophageal reflux disease. After verifying these are correct, we should include these diagnoses within the patient's chronic problems in the problem list. Our third resource will be results from labs, imaging, and other studies. If you find additional clinically significant problems in these sections, you should add them to your problem list. Let's say our patient's labs happen to show a hemoglobin, or HGB, of 8, with a mean corpuscular volume, or MCV, of 72. We review their prior labs over the last 2 years and find a similar baseline hemoglobin and MCV. Now, we have found an additional problem that should be addressed. Applying what we learned before, we can call this problem chronic microcytic anemia. Putting this all together, we now want to go through and prioritize the patient's medical problems in our problem list. The first problem should be the most severe diagnosis, even if it is not the main problem that prompted admission. This helps us draw attention to and spend the most time on this diagnosis. After this, list any active medical problems. By this, I mean medical problems that you are actively intervening on during this hospital stay. Finally, list the patient's chronic medical problems that need to be noted but may not be actively managed during their admission. An extra tip to prevent your problem list from becoming a laundry list that is hard to sort through is to use qualifiers like stable or resolved. This helps separate clinically active problems from problems that are stable or less active. For example, if our patient has a history of asthma without any recent exacerbations, you could label this problem as chronic asthma stable. This can also help delineate problems that were previously of high clinical significance but have since improved. For example, if our patient recently had symptomatic anemia that resolved after transfusion, you could call this problem acute symptomatic anemia resolved. Resolved or stable problems can be considered lower on your problem list. One other helpful tip is to note if a new problem was present on admission or not. You might see this abbreviated as POA. This is especially helpful to note for clinical problems that might result from iatrogenesis, such as device-associated infections or pressure injuries. As the days go by in your patient's hospital course, it is important to remember that the problem list for your patient is fluid. The order of problems may ebb and flow. For instance, if a patient was initially admitted for a COPD exacerbation, but then develops sepsis from a urinary tract infection. The problem sepsis might rise to the top of your problem list. The COPD exacerbation might decline in priority, especially if it has resolved.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.